Gartland classification everyone knows of. There is a Wilkins modification. So Wilkins modification has to do with type 2 fractures where you have an intact posterior hinge. So 2A is a pure extension type and 2B is extension with rotation. And that is Wilkins' addition to the standard Gartland classification. So I've struck out 1, 3 and 4 because the management of those is very clear. 3 and 4 require fixation every single time. 1 does not need anything doing. The 2s is where there is doubt. So this is a 30-second algorithm. It's done by Dr. Teddy Schlongo to get the classification of supracondylar fractures. So you basically look for broken cortex. If there is any translation at all, it's a 3 or a 4. Even if the two bones are in contact, the bones do not have to be like this for it to be a 3 or a 4. They can be in contact. If there is any translation, then it's a 3 or a 4. It's basically a 3 that's come back and sat down. It's still an unstable injury, yeah? So if there is no translation, then you basically look at a true lateral view, yeah, true lateral view. And then you draw the anterior humeral line or the Rogers line. And then you look at to see if the Rogers line goes through the middle of the capitulum. If the Rogers line goes through the middle of the capitulum, as it normally does, then it's a type 1, it's an undisplaced fracture. If the anterior humeral line passes anterior to the center of the capitulum, then there is some amount of extension. So it's a type 2, yeah? And then we look at subtypes of type 2. And so that's the anterior humeral line going through the center, that's a type 1. Anterior humeral line not going through the center is a type 2. So why is type 2 interesting? Because type 2s are the ones in long-term studies that don't do well, yeah? So bone remodeling cannot be relied upon to correct residual deformity. So type 2 fractures appear to have an impaired long-term outcome. So it's something that needs our attention. One more study published in the JBJS that show that those type 2 supracondylar fractures that are treated conservatively had mild cubitus varus deformity and a mild increase in elbow extension. They all ended up with hyperextension, though functional outcomes were quite okay. So the conclusion in the last 10 years is that we are potentially under-treating type 2 supracondylar fractures. And there's one more paper from the JPO that shows that casting is insufficient for most type 2 supracondylar fractures. So the traditional teaching is that type 2A requires manipulation and casting. But then if you look closely at type 2A, this is a 2A, yeah? Anterior humeral line is not going through the center of the capitulum. There is some extension. And this is also a 2A. There's no rotation, yeah? But the anterior humeral line is not touching the capitulum at all. Both are type 2As, but as we shall see, the management of them is slightly different. So there are two subtypes of 2A whether the anterior humeral line touches the capitulum or not. So predictors of failure, this is another paper in the JPO. So they said two predictors of failure. One is when the capitulum extends completely beyond the anterior humeral line. So anterior humeral line, when you draw it, does not touch the capitulum at all. And number two, when you have a large swollen arm where just casting does not maintain the reduction. So these are the two indications when a type 2A fracture will need close reduction and pinning. So let's look at this example. A girl who came to me with fall on the outstretched hand, 6 years old. On the initial post-injury film, the anterior humeral line was touching the capitulum. So I elected to treat this in plaster. But a week later, when I got a check X-ray, I found that there was further displacement. So this girl went on to require close reduction and percutaneous pinning through standard technique. 2 lateral pins is what I use. So type 2B is when you have extension with rotation. So the way to look at rotation is look at the width of the two fragments of the fracture. If they are equal, then there's unlikely to be rotation. If they are unequal, then you know that there is rotation. So when you have unequal lengths, and we shall look at an example. And the problem with having rotation is when you have rotation, because the width of the humerus at the supracondylar area is very thin, when you get rotation, they then tilt into varus. And the problem is, of course, varus. So these require, so 2B always requires close reduction and percutaneous pinning. So example of a type 2B, you can see that there is unequal, on the X-ray on your right, you can see that there is unequal width of the supracondylar area. So this required again close reduction and percutaneous spinning. But it's important to get a true lateral view. So this is a Sunday afternoon. This is the X-ray that the ER doctor sends me. It looks okay, doesn't it? Yeah, it doesn't even look on the first X-ray that there is a definite fracture there. So I didn't accept it and I told them to take one more X-ray. So you can see that. So that's the second X-ray they sent me, and I still wasn't happy with that. So I told them to take a third X-ray and get a true lateral view. And this can be a problem because children are in pain. It's very difficult sometimes to get a proper lateral view. And this is take 3, and you can clearly see now that this is a 2B. Yeah, you can see you're getting an AP of the proximal fragment and a lateral of the distal fragment. Yeah, so that's a 2B, and so that's an intraop film. You can see that clearly there is rotation when you get a true lateral, and then we reduce that, and then pass 2 pins, and that does satisfactorily. The other thing to be aware of is the varus impact at 2A. So always look at the medial supracondylar ridge. Look for either varus impaction or medial comminution, and these are danger signs. And again, these are all indications for fixation. So this is a type 2 with medial impaction, which was treated conservatively by a surgeon outside, and then that's the way it healed. And then that is a year later, you can see clearly that the child has developed cubitus varus. So always look at the medial column to make sure that there is no varus impaction or medial comminution. There are other treatment approaches. Instead of a standard lateral pin, 2 lateral pins or a cross pin, for a 2A, because it's a relatively stable fracture, you don't need a lot of fixation for these. So this is a paper again in the JPO that said that a properly selected Wilkins 2A fracture, when you can get a near anatomical close reduction, like I've shown you in the previous cases, you can get bicortical lateral entry smooth pinning. You can get away with a single pin. Yeah, it's a single pin. So it's just a derotation pin, which is passed on the far lateral side, just a single derotation pin, because the medial side is quite stable. So if you carefully select, just a single lateral pin will be sufficient to stabilize these injuries. So treatment of supracondylar fractures has evolved from selective pinning of type 2 fractures to pinning all type 2 fractures, and the current study demonstrates the efficacy of using a single entry lateral pin, yeah, for stabilization. So in summary, type 2 still has further subtypes. The first one is a 2A, where the anterior humeral line touches the capitulum and the arm is not swollen. In these, you can watch them closely, but please do take X-rays at a week or even X-rays at weekly intervals for 2 weeks. And then you have a 2A, where the anterior humeral line is clearly in front of the capitulum. Yeah, so the capitulum is behind the anterior humeral line, and or you have a swollen arm. In these, I think it's better to do close reduction and percutaneous pinning, and there is some evidence to say that a single pin may be sufficient in these. And then you have this, the 2B, which is extension with rotation, where you have to do a standard pinning, 2 lateral pins or cross pinning. But the trend is towards close reduction and percutaneous pinning of most type 2 fractures, because these tend to go into cubitus varus when followed up in the longer term. Thank you.